Hello and welcome to today's webinar. We're going to wait just a minute or two to allow the attendees to enter, but I'm glad to see so many of you joining today. Welcome. All right, well, I'm going to kind of get started with some welcoming comments. I know that a few more of you will be coming in here shortly, but my name is Paul Bunch, and I'm a neuroradiologist at Wake Forest. I'm also a proud member of the ASHNR, and it is my pleasure to serve as a moderator for today's Talking Heads and Necks webinar. My co-moderator for today is Dr. Bruno Policeni from the University of Iowa, and I'm excited to be working with him. Before getting started, I'm going to go over a few housekeeping items. And first, I'd like to pause on this slide for a moment and just acknowledge how cool it is. The languages you see represented correspond to the official languages of the various countries which you, the attendees, represent. Yes, it is called the American Society of Head and Neck Radiology, but we are so excited to be reaching an international audience with these webinars. And for anyone watching who has not yet become a member of our society, no matter what country you reside in, we would love to have you because we know our society will be better and stronger with your involvement. I suspect that many of you have already heard about our upcoming virtual meeting and have already registered, but if you haven't, I think you really need to. The content will be outstanding. The cost is modest, and it will be delivered to you at the convenience of your home or wherever you happen to be. If you'd like, you can register now using this link or the QR code provided. If you would like to ask a question of our faculty during today's webinar, you may do so by entering a question in the Q&A chat, or sorry, the Q&A panel, excuse me. Use the chat function to connect with fellow attendees throughout the session. So again, questions in the Q&A, chat for connect. You can minimize the chat box if you decide you don't want to see the chat alerts or the messages. CME credit is available for this webinar, and it's available on the ASNR Education Connection website. Membership is not required, but if you do not already have a login, you will need to create one. This webinar is being recorded and will be available on the ASNR Education Connection soon. On this slide, you can see the webinar learning objectives, faculty disclosures, and accreditation statement. We're thrilled you're here today, and we really hope you can join us for our final 3 webinars leading up to our September virtual meeting. The topics and speakers for our August 13th, August 20th, and August 27th webinars are listed on this slide. And finally, I will introduce today's speakers, both of whom I greatly admire. Our first speaker is Dr. Christine Glastonburry, and she will be discussing the trigeminal nerve. Dr. Glastonburry is an Australian radiologist who then worked at the Hammersmith Hospital in London for a year before her neuroradiology fellowship in the USA. In Utah, she was insanely lucky to have as co-fellows Dr. Karen Salzman, Dr. Phil Chapman, and Dr. Rick Wiggins during her second year of fellowship. Dr. Glastonburry has lived in San Francisco since 2001, where she is the interim chief of neuroradiology at UCSF and the vice chair for academic affairs, where she gets to participate in teaching and marveling at brilliant neuroradiology fellows, trainees, and faculty every day, although mostly via Zoom. Dr. Glastonburry is honored to be the current Education Committee Chair for ASHNR and is waiting for people to work out that she never intended to have an academic career. Our second speaker is Dr. Rick Wiggins, and he will be discussing the facial nerve. In addition to being a talented radiologist and educator, Dr. Wiggins is also a gifted humorist. I cannot disclose who wrote his introduction, but I will deliver it just as I have been instructed. So here goes. I see that Dr. Glastonburry's introduction is short and sweet, so mine must be long and spicy. Dr. Wiggins is a Cajun Texan radiologist who was previously confused for a few years in Florida, where that happens a lot, thinking that he wanted to be a head and neck surgeon, but he eventually saw the darkness. In Utah, Dr. Wiggins was insanely lucky to barely survive fellowship. Don't ask, he is not allowed to talk about the issues, and has lived in Salt Lake City, partying like it's 1999 ever since. He often sits in a dark room by himself, seemingly randomly looking at pictures from the internet on big computers and contemplating past life choices. But sometimes, when he hasn't been acting up, he gets to participate in teaching and most awesome marveling at the even more brillianter than those other guys, Utah head and neck imaging fellows, neuroradiology fellows, ENT surgery fellows and residents, trainees, and some of the neuroradiology faculty each and every day. Sadly, mostly virtually, but sometimes while wearing pants. Who really knows these days anymore? Dr. Wiggins is honored just to wake up each morning at this point and try to figure out what the day's damage report is before calculating the risks of getting out of bed and interacting with other humans because, well, people are funny. Thank you for joining us. Our first presentation will begin shortly.
So thank you, Paul, and thank you, Bruno, for the warm introduction. It's really great to be part of this webinar, and I hope that everybody who's listening is feeling well, they're masked up, sanitizer ready, and we're going to talk about trigeminal nerve imaging. These are my disclosures. So there are two main points that I want to make in this lecture today. Number one is that anatomy is really key to all cranial nerve imaging. And this has never been more true for the trigeminal nerve because it has very complex nuclei and very complex nerve branches. And you really have to learn those trigeminal nerve landmarks. The second point I want to make is that I want you to understand by the end of this lecture the difference between trigeminal neuralgia and trigeminal neuropathy, and really understand that TN is really a type of neuropathy, but this is really important because not everybody knows this, and that means sometimes you're referred cases that are called trigeminal neuralgia that are really trigeminal neuropathy. So let's talk about the trigeminal nerve anatomy first. So this is a really big nerve. It has a large sensory component, which is sensory to the face, the conjunctiva, the paranasal sinuses, the teeth, the tongue, the external aspect of the tympanic membrane. And it even has sensory supply from the anterior and middle fossa meninges, which is why you may get those ice cream headaches. It has a much smaller motor component, which is only traveling with the mandibular division of the trigeminal nerve. And this is motor to all of the muscles that insert onto the mandible, except genioglossus and geniohyoid. And it's also motor to the tensor veli palatini and the tensor tympani muscles. And these are all first branchial arch nerves, the sensory component and the motor component. Now, let's just diverge a little to talk about trigeminal neuralgia and why I think it's really important to understand this for trigeminal nerve imaging. So TN is a very specific pain syndrome. Patients present with this incredibly intense, sharp, recurrent episodic pain in their face. And it is only involving the second and third divisions on one side. There are a number of different names that come with this, the most horrific being the suicide disease. And that is because patients with TN often have the syndrome for years before they're actually diagnosed with this, and they have no relief from the pain, and it is so bad that they really need to do something terrible about this. Now, the syndrome is also characterized by these trigger zones. So that's areas on the face or in the mouth when a patient is brushing hair or brushing teeth or is shaving. They have this onset of one of these episodes of recurrent pain. And over time, they tend to have more episodes of pain and fewer pain-free intervals, and they can develop an increasing number of trigger sites. So this is a very, very specific syndrome, typically in patients over the age of 40 who present with this pain. And there are two kind of groups of causes. Most cases, depending on who you look at in the literature, which are known as the classic cases, the cause is thought to be neurovascular compression. And that is typically an arterial branch, but sometimes a venous branch within the cerebellopontine angle, which is compressing the root entry zone of the trigeminal nerve at the brainstem. Now, there are secondary causes, and I'm going to show you some. So people with true TN, where there are other pathological causes that result in the presentation with TN. So that vascular loop at the root entry zone of the trigeminal nerve is most often arterial, and it's due to the superior cerebellar artery branching down onto that proximal aspect of the trigeminal nerve. Now, AICA and PICA branches have also been invoked, and you can have venous causes with the superior petrosal vein being the cause of this neurovascular compression. So just to bring this all around together and to clarify why this is important, patients may have cranial nerve 5 symptoms, and they can be either facial pain or, because it is sensory, it can have dysesthesias, tingling, or numbness. Or they could have motor symptoms. Now, if it is true facial pain that they're presenting with, it may be trigeminal neuralgia, and that is that very, very specific syndrome with recurrent episodic severe painful episodes involving the second and third divisions. Or it may be a constant facial pain or a facial aching, or it does not fit the actual diagnosis of TN, and that is facial neuropathy, trigeminal neuropathy. Now, if it is actually a true TN, it could be classic due to neurovascular compression, or it could be secondary, and in which case you need to be imaging for causes of fifth nerve pathology other than nerve root compression. If it is facial pain that does not fit the definition of TN, you also should be looking for fifth nerve pathology. And if it's not pain at all, it's one of these other symptoms, you're definitely looking for fifth nerve pathology. So now that you're imaging for fifth nerve pathology in a patient, no matter what their presentation with fifth nerve symptoms, you need to understand the anatomy, because that is critical here. So you need to be very, very comfortable with the complex nuclei all the way out to the complex peripheral branches. So we have the complex nuclei in the brainstem, so we need to be imaging to looking for tumors, demyelinating disease, infarct, Lyme disease, other inflammatory causes. We need to be imaging the cisternal segment all the way through Meckel's cave, skull base, to look for cerebellopontine angle masses, skull base masses, leptomeningeal processes involving this. And this is the largest cisternal cranial nerve. It's pretty easy to image. And then as we come out to the peripheral branches, you need to be looking for peripheral nerve sheath tumors, perineural tumor, inflammatory processes, things that are involving the branches to present with fifth nerve symptoms. So let's look a little more closely at the brainstem and the trigeminal nerve nuclei. And it really is very complex brainstem nuclei. So the motor component is in the mid aspect of the pons and is medial to what is colored in blue here, the chief sensory nucleus. So this motor component here will come forward through Meckel's cave, not synapsing in the Gasserian ganglion, but through here and exit out through foramen ovale as the motor component of the third division of the fifth cranial nerve. Now, let's look at the sensory nuclei within the brainstem. So that chief sensory nucleus that I've done here in light blue, which is lateral to that motor component, is important for light touch within, and is centered in the mid-pons, known as the chief sensory, main sensory, or principal pontine nucleus of the trigeminal nerve. Now, ascending northwards from that, we have the mesencephalic nucleus. There are primary sensory nucleons in the CNS here that are important for proprioception. For example, the chewing of muscles or the movement of your tongue in your mouth. And there is also proprioception of your extraocular muscles, with that supply coming from the first division of the fifth nerve, which supplies the orbit. Now, inferior to the chief sensory nucleus is the spinal nucleus and tract of the trigeminal nerve, which is primarily responsible for pain and temperature perception, with some tactile information also projected to the chief nucleus, as well as being projected here. So this is the longest component of the trigeminal nucleus, and we have the three components within it: oralis, interpolaris, and caudalis, with caudalis being the lowest. And this is the most important because all fibers that carry facial pain and temperature terminate within this nucleus. And the critical thing to be aware of is in imaging is this goes all the way from the pons down to the upper cervical cord. So let's look at those landmarks on imaging, and this is axial 7T imaging here. And we can see the cisternal segment. We're here in the pons, and this is where we're going to find the motor nucleus with the chief sensory nucleus lateral to it. So imaging down inferiorly from that is where this nucleus of the spinal tract of the trigeminal nerve is going to descend all the way to the upper cervical cord, and that is where you need to be imaging all the way down there if you're looking for a cause of trigeminal symptoms. So this is a patient presenting with true left trigeminal neuralgia. We have axial T2 weighted images. We're right at the aspect of the pons here, superior aspect of the pons, and I can see that we have part of the cisternal segment of the fifth nerve. But you can see within the lateral aspect of the pons, this T2 hyperintense focus, which on the sagittal flare you can see quite nicely too. Now, there's a number of things for the differential here. There was no enhancement, no restricted diffusion. And this was thought to be an old infarct. It could be a demyelinating lesion, but she had no other intracranial lesions that went along with this diagnosis. This was a patient presenting kind of in a subacute presentation with right trigeminal neuralgia. Subacute is a little odd because most patients with TN present with about 3 years of pain and often a lot of dental work and dental investigation before someone calls it trigeminal neuralgia. But it was, after the imaging was done, clarified that the patient's symptoms were numbness. So this is not really trigeminal neuralgia. Anyway, this is a trigeminal neuropathy. And on this imaging, you can see an expansile T2 hyperintense lesion in the lateral aspect of the pons, involving the brachium pontus as well. And you can see on FLAIR, it has kind of a cystic component centrally. And post-contrast, you can see that peripheral enhancement, and then enhancement extending along the proximal cisternal aspect of the trigeminal nerve. And this was found to be a GBM on biopsy, presenting with facial numbness, trigeminal neuropathy. So let's look more at that cisternal segment, and then we're going to move towards the branches of the trigeminal nerve. So we have the cisternal segment, the largest cisternal cranial nerve, either side of the pons. And on the coronal, I usually look on the T2 for the cochlea. When you see the cochlea there, you can usually see the trigeminal nerve sitting either side of the pons. More anterior to that, you will see the CSF-filled Meckel's cave, which contains the Gasserian ganglion, also known as the semilunar ganglion. And this contains cell bodies for sensation. There are peripheral branches that will go from here to the pain and temperature receptors in the entire face, paranasal sinuses, tongue, palate, etc. And then central process come back from here that go to the brainstem spinal tract for the pain and temperature, and also the chief sensory nucleus. So this Gasserian ganglion is where, when patients have a Gasserian ganglion block for trigeminal neuralgia, someone is injecting up into the Gasserian ganglion. Usually they go in through foramen ovale in order to get into here for patients with TN as a treatment. So here's a patient who has left trigeminal neuralgia. Now that's a bit of a red flag history because patients with TN are usually over the age of 40. And on the axial T2, you can see that there is a CSF isointense something or other causing mass effect on the pons, deforming the pons, and also displacing that cisternal trigeminal nerve laterally. And we can see on the coronal as well, there's no enhancement. This is coronal post-GAD, no enhancement. The nerves displaced laterally. And for most radiologists, this is pretty straightforward. We've got a CP angle mass that is non-enhancing and CSF iso-intense. We need diffusion to tell if this is an arachnoid cyst or an epidermoid. And clearly, this is an epidermoid that is presenting with a trigeminal neuralgia in this young patient. This is another patient with trigeminal neuralgia, and we can see on the right normal CSF in Meckel's cave, nice cisternal nerve, but on the left we've lost that bright T2 of Meckel's cave, so something is filling in Meckel's cave, and we've got this smudgy appearance of the cisternal segment of the trigeminal nerve. And if we put on a little contrast, things get a lot clearer. We have a durally based mass here involving the margin of the tentorium extending into Meckel's cave, and this is a meningioma presenting with left-sided trigeminal neuralgia. Another patient here presenting with what was originally thought to be left trigeminal neuralgia and headaches, and hence they got an MR scan for that. But on reading the electronic medical record, the pain was really the whole left face. So the first division is very uncommonly involved with true trigeminal neuralgia. But if we look at this pons, you can see cisternal fifth looks nice bright signal in Meckel's cave. Here's a nice foramen rotundum, but on the left side you can see there's an expanded appearance of foramen rotundum in this case, and it looks like something is pushing on the middle cranial fossa here on the anterior aspect of the temporal lobe, and again a little GAD makes life a whole lot easier. We can see we have another durally based mass here that is involving the second division of the fifth nerve, as well as involving the cavernous sinus, and this was a grade 1 meningioma at resection. So let's look at those branches, because we need to be really comfortable with those branches out that come out from the Gasserian ganglion. So let's start with the first branch, which is the ophthalmic branch of the trigeminal nerve. It comes from the Gasserian ganglion through the superior lateral aspect of the cavernous sinus to the superior orbital fissure. So those are the first two of our landmarks we're going to be thinking about for this branch. It enters the orbital apex and it has three branches: the nasociliary branch, the frontal branch, and the lacrimal branch. And the frontal branch is going to course over the top of the levator palpebris superioris and the superior rectus muscle, and then emerges out onto the forehead because it supplies the forehead and the anterior scalp with sensation. Therefore, if there is a process here, a malignancy here, it can travel back along this branch. But the other branches, the nasociliary is important for supplying the conjunctiva. And then, of course, we have some proprioception from branches of these nerves to the extraocular muscles that feed back to that mesencephalic nucleus. Now, the second division is the maxillary division, also from the Gasserian ganglion through the lateral aspect of the cavernous sinus, but then it goes through what is called the foramen rotundum, but is really a canal of rotundum, to the pterygopalatine fossa. So rotundum and pterygopalatine fossa, as well as the cavernous sinus, are further landmarks to be very, very comfortable with for imaging. From here, there are branches down the greater and lesser palatine nerve to supply the hard and soft palate respectively, as well as the greater palatine nerve supplying the teeth of the upper jaw. We also have branches to the paranasal sinus, and then we have the infraorbital nerve coming along the infraorbital canal out to the cheek and supplying the skin of the cheek and the lateral aspect of the nose. The third division, of the mandibular division, does not go to the cavernous sinus, but from Meckel's cave drops straight down through foramen ovale. There are two motor branches, the masticator and mylohyoid nerves, and then four sensory branches. And there's going to be all the sensation to the mandible. So the actual mandible itself, the teeth, the floor of the mouth, sensation of the anterior 2/3 of the tongue, and then a branch is going to go through as the inferior alveolar nerve through the mandible to emerge onto the jaw, the chin area, to supply the chin and the lower lip from the mental foramen. So here's a patient presenting with intense left forehead eye pain. So we're focusing then on the first division, the ophthalmic division, and remember our three main branches in there. We're thinking of our landmarks that we need to be looking at. And so on these non-contrast T1 images, you can see that we have this big, thick, chunky frontal branch of the ophthalmic over the top of the levator palpebris superioris and the superior rectus muscle. And this is squamous cell carcinoma recurring as perineural tumor. And this patient had previously had a resected and lightly radiated forehead following squamous cell carcinoma resection, a little radiation, but he has recurred as perineural tumor. And you need to image the whole way back to the pons when you're looking for the true extent of perineural tumor. What about this patient here presenting with right cheek pain? Well, we're going to be thinking about our landmarks of the maxillary division of the trigeminal nerve. And on this axial T1, we can see loss of the normal fat in the right pterygopalatine fossa, and we can see that area enhances intensely with contrast. On the coronal T1 and the axial T1, here's normal fat in the palate on the left side, but complete replacement of the normal palatal fat on the right side, that's bony fat. It's completely replaced by this infiltrating palatal adenoid cystic carcinoma that's hopped onto that greater palatine nerve and made its way to the pterygopalatine fossa. And you need to image back through rotundum all the way back to the lateral aspect of cavernous sinus, Meckel's cave, cisternal, trigeminal nerve to follow the full extent of tumor. Another patient, previous Gasserian ganglion blocks for TN, but what was missing was the history that they'd had a squamous cell carcinoma resected. We have a big soft tissue mass. This was actually palpable, but kind of no one thought it was related. And this is squamous cell recurrence right out where that infraorbital nerve comes out onto the cheek, but it was traveling back along the infraorbital nerve to the pterygopalatine fossa, presenting with what was thought to be trigeminal neuralgia. A patient with right lower lip and chin numbness, we're going to be thinking about that third division. We must be looking at the branches of the mandibular division of the trigeminal nerve to see if there's any peripheral cause for a problem. So here we have a patient axial T1, axial T2 weighted images. We can see this asymmetric loss of normal fat signal within the right hemimandible, bright on T2. On a coronal, here's a normal left-sided enhancement around the inferior alveolar nerve, huge, thick, chunky nerve on the right side in this patient. And this was melanoma. The patient had had a melanoma of the lower lip excised 4 years prior, and this was presenting with a chin numbness and lip numbness from this perineural tumor. You can even see it on the FDG PET, which is not common. Okay, so that is a whirlwind 20 minutes run through the trigeminal nerve. The 2 points I want you to take home with you is that anatomy is key to all cranial nerve imaging, and you must know the complex trigeminal nerve nuclei, get comfortable with the cisternal course to Meckel's cave, and then the 3 branches going through the skull base to the entire face. And you must image all of them, the entirety, when you have a patient who may have trigeminal neuropathy. Now, be aware that trigeminal neuralgia is a specific syndrome. It's a type of cranial trigeminal neuropathy. And sometimes scans come with a history of trigeminal neuralgia, but it's really neuropathy. So anytime you're reading a trigeminal neuralgia scan, assume it's neuropathy. Look for other causes of trigeminal nerve pathology. And when you're finished with that and you haven't found anything, then look for neurovascular compression in this patient. I want to thank you so much for your attention, and I'm really looking forward to hearing some of your questions after we listen to Dr. Rick Wiggins now talk about facial nerve anatomy and pathology. Thank you so much.
Hello, this is Rick Wiggins from the University of Utah, and we're going to take a whirlwind tour through the facial nerve, cranial nerve 7. I have nothing significant to disclose. I don't own the facial nerve. I don't make money if you learn about the facial nerve, but I will tell you that it's pretty much the best nerve ever. So like everything else in the head and neck world, the anatomy is very important. So we're going to talk about the anatomy of cranial nerve 7. Then we'll look at some of the pathologies that happen to that anatomy, and we'll look at the imaging characteristics and see how we can make differentials based on those imaging characteristics and how they're similar and how they're different. So we'll start off first with the anatomy of the cranial nerve 7, the facial nerve. And we think about it as existing in different segments. So we have a segment of the facial nerve that's in the CP angle cistern, so that's a cisternal segment. There's a segment going through the interlaudatory canal, so that's a canalicular segment. There's a portion going through the labyrinthine part of the ear between the cochlea and the vestibule, so that's the labyrinthine segment, to the anterior turn, or the geniculate ganglion. That's where the greater superficial petrosal nerve comes off. Then we have a tympanic segment going back under the lateral semicircular canal. Then we have a descending or mastoid segment and an extracranial segment. And this is a complicated mixed nerve. It has 3 main functions that we think about. So majority of it we think about as branchiomotor, the voluntary and involuntary muscles of facial expression that are controlled by the facial nerve. But we also have some visceral motor, parasympathetic innervation, not only to the lacrimal gland, but also the submandibular and sublingual glands. And we have special sensory taste with the chorda tympani to the anterior 2/3 of the tongue. So if we think about three main functions of the facial nerve, it makes sense that we have three main nuclei that make up the seventh nerve. So this is an axial graphic through the level of the fourth ventricle, and the little bumps on the front of the fourth ventricle, the facial colliculi. The motor nucleus under that is 6. The fibers of 6 come out anteriorly at the pontomedullary junction off midline. The motor fibers of 7 in the motor nucleus is actually immediately anterior and lateral to 6. And the motor fibers of 7 do a strange thing. They start in the wrong direction. They wrap around 6 to contribute to that facial colliculi, and they come out the bottom of the pons ventrolaterally. And they pass in between the superior salivatory nucleus, joining those fibers, and the solitary nucleus or solitary tract. So we think about the main motor nucleus, we think about the parasympathetic visceromotor, and we think about the special sensory up here at this level, the taste to the anterior 2/3 of the tongue, as the seventh nerve. So it comes off inferiorly in the pons ventrolaterally. So here's an anterior graphic. We see the pons, we see the medulla. So here's 6 coming out the pontomedullary junction. 7 and 8 are often drawn coming out at that level. They really come out the bottom of the pons. There's a cisternal segment and then a canalicular segment as they enter the interlaudatory canal. So in the interlaudatory canal, we see separation of those nerves. So here's the superior and the inferior vestibular nerve with the cochlear nerve, and here's the facial nerve anteriorly and superiorly in the internal auditory canal. If we think about the different functions of the facial nerve, here in this graphic, we've divided out those functions by color. So here in yellow, we see the motor fibers that pass all the way through the intertemporal portion, mostly to come out the stylomastoid foramen for the voluntary and involuntary muscles of facial expression. In green, we have the greater superficial petrosal nerve coming off the parasympathetic innervation to the lacrimal gland, but we also have some of those parasympathetic fibers that travel along with the orange chorda tympani here at this level that goes through the middle ear cavity, and those fibers go down through a small fissure anteriorly in the temporal bone to join the anterior division of V3 to form the lingual nerve. So here in green, we see those visceromotor parasympathetic innervation fibers. In orange, we see the special sensory taste of the chorda tympani. And in yellow, we see the motor fibers that go all the way through the temporal bone. Again, we have a canalicular segment through the IC, the labyrinthine segment that goes to the anterior genu, where we have the geniculate ganglion with those parasympathetic fibers. Then we have a tympanic segment that goes back under the lateral semicircular canal to a posterior genu, and then a descending or mastoid segment that has 2 branches, the little stapedius nerve that goes to the stapedius muscle that goes to the stapes, and the chorda tympani that comes off at that level. So on an axial graphic, we again see those cisternal segments, the canalicular segment, the labyrinthine segment of the facial nerve going in between the cochlea and the vestibule to the anterior genu. The greater superficial petrosal comes off going immediately lateral to the horizontal segment of the carotid. Then we have the tympanic segment of the facial nerve going under the lateral semicircular canal to the posterior genu, and then a descending or mastoid segment that's going down inferiorly through those mastoid air cells posterior to the external auditory canal. Now, in the middle ear cavity, we can think about those 2 branches off the descending or mastoid segment. So here's a Netter graphic, and we're looking medially at the cochlear promontory. We see the anterior and posterior curve of the stapes. Here's the tympanic segment of the facial nerve under that lateral semicircular canal. Here's the greater superficial petrosal nerve coming off anteriorly from the anterior genu. And from that descending mastoid segment, we have the little stapedius nerve that goes to the stapedius muscle that goes to the stapes to help clamp down motion during loud noises. If we were to turn around from this view and look laterally, here's the tympanic membrane, and we see the sharp turn that the chorda tympani nerve makes coming off that descending mastoid segment as it droops through the middle ear cavity in between the malleus and the incus, going anteriorly. So that's the chorda tympani, the second branch off the descending mastoid segment. Those fibers of 7 continue down inferiorly. They come out the stylomastoid foramen. We think about them as dividing the parotid into a superficial and a deep lobe. That's just a cross-section discussion when we think about the facial nerve going through the parotid itself. But it splits there in the pes anserinus, the goose's foot, and the parotid as those divisions go out through the face. So we have a temporal, zygomatic, buccomandibular, cervical, and occipital branch of that pes anserinus within the parotid. There's another pes anserinus in the knee, but that's not important. Only the one in the parotid is important. Also in this graphic, we see those two branches coming off the descending or mastoid segment, the stapedius nerve and the chorda tympani, and we see the nice fat pad. We want to see a good fat pad at every orifice when we think about those cranial nerves coming out of the skull base. So that's the graphic anatomy. On imaging, on your axial CSF bright sequences, whether it's a T2-FSC with FATSAT or a CASE or a SPACE, KISS, SPACE, FIESTA, whatever your sequence is that's CSF bright, that's where we will see the cisternal and the canalicular segment nicely of the seventh nerve. If we do oblique sections through the lateral half of the internal auditory canal, we see the separation of those nerves. Here's the cerebellum, so I know that's posteriorly, so I can remember those nerve positions by 7 up and coke down. The seventh nerve is on top and the cochlear nerve is on bottom. And the superior and the inferior vestibular nerves will divide out into their separate nerves and the lateral half of the IAC. So the seventh nerve we can follow anteriorly and superiorly, and there some may be a little bit of CSF going along that labyrinthine segment and between the cochlea and the vestibule where the facial nerve is going. So we can see the semicircular canals and coming off the vestibule, and we see the cochlea here anteriorly. Look, it's a boy. On the CT, we'll see the intraosseous segments best of the facial nerve. So here's the labyrinthine segment going anteriorly on this axial bone algorithm CT to the anterior genu. Then we'll see the tympanic segment going under the lateral semicircular canal. So near the level of the ice cream cone of the ossicles is where we'll see that tympanic segment. So the ice cream scoop is the head of the malleus and the cone is a short process of the incus. Then we'll have a posterior genu posteriorly, and then a descending or mastoid segment going down through those mastoid air cells posterior to the external auditory canal. So if we think about that tympanic segment where it meets the descending mastoid segment and we do an oblique section through that course, we'll get the posterior genu and that descending mastoid segment at that level. So again, from that descending mastoid segment, we think about two little branches coming off. If we look at an axial CT below the ice cream cone, we see the pyramidal eminence, a little bump shaped like a pyramid right there. The air-filled space next to the facial nerve descending segment we call the facial nerve recess, and we think about the sinus tympani as the lateral aspect from the bottom of the pyramidal eminence over to the windows. Here we see a dot of air where the round window is. And we can see here that little stapedius nerve going over to the superstructure of the stapes with the anterior and the posterior crura at that level. So that stapedius nerve is the first branch. The second branch is that chorda tympani that does a sharp turn and drapes through the middle ear cavity itself at that level. So if we do an oblique reconstruction of the posterior genu and descending mastoid segment, we can sometimes see that chorda tympani branch coming off and going up through that level. So that's the second branch at that level. Now at the anterior genu, that's where we have the greater superficial petrosal nerve come off. And on a pathologic case, here we see AV enhancement along that course. We see a lot of enhancement along that greater superficial petrosal nerve, as well as the labyrinthine segment and the tympanic segment. So we can follow that greater superficial petrosal nerve. There's always a break in the bone anteriorly at the horizontal segment of the carotid. That's where the sympathetic fibers that travel the carotid join the parasympathetic fibers from 7, and together they form that long, thin, curvilinear pterygoid or Vidian nerve through the pterygoid or Vidian canal that goes forward to the pterygopalatine fossa. Now, if you ever want to explain the facial nerve, you can take a paper clip, this is a paper clip, and unfold it to make the facial nerve. So if we think about this in the real world, this is a left temporal facial nerve. I cleaned my fingernails before I made this video. So if we unfold the paper clip, we have a little IAC canalicular segment to the labyrinthine segment. Then we have a tympanic segment going back to the posterior genu, and then a descending or mastoid segment going inferiorly. So that's the anatomy of the facial nerve. Now we'll look at the pathology that happens to that anatomy. Now it is normal to have some enhancement of the facial nerve. So about 2/3 of the case will have some avid enhancement along the facial nerve, and about 2/3 of those will be asymmetric. So we might see more on one side than the other. That's okay. We don't judge. So we more often see that enhancement around the geniculate ganglion at that anterior genu. So we see enhancement at the anterior genu, next commonly at the tympanic segment, next most commonly labyrinthine segment, and least commonly along the descending or mastoid segment. So if we do see avid enhancement and we think it's abnormal, we should not see an enhancement along the cisternal segments of cranial nerves. But if we do see abnormal enhancement, we may think about doing a CT to evaluate those intraosseous canals. If we do have trauma of the temporal bone and we think about fractures, we often describe them historically as being longitudinal along the axis of the petrous apex and the pyramid, or transverse being perpendicular to that. Here we have a transverse fracture, and we see it going through the labyrinthine segment of the facial nerve. Anytime we do have a fracture, we try to mention, is it otocapsule sparing or otocapsule involving? That otocapsule, again, being that dense bone that's around the cochlea and the vestibule. So this is an otocapsule involving transverse fracture that goes through the labyrinthine segment. Now, if we do see abnormal enhancement, we want to think about the important differentials here. Now, sometimes these look similar and sometimes they're very different, and we think about doing both CT and MRI. We know they're complementary at this level, so we sometimes do both. We don't feel bad about that. So if we have a CT, we sometimes recommend a contrasted MR, and if we have a contrasted MR, we sometimes recommend doing a bone algorithm then CT through the temporal bone to evaluate these structures. So first we have a herpetic or a Bell's palsy. We think about this as an idiopathic acute onset lower motor neuron facial paralysis. On CT, those osseous canals are normal, but on MR, we have asymmetric, diffuse, and tense enhancement all the way along its course and a tuft of enhancement laterally in the IAC. So here's an axial post-contrasted MR and the correlating oblique sagittal. We see a tuft of enhancement in the lateral IC. We see the labyrinthine segment going to the geniculate ganglion, the anterior genu, then the tympanic segment going back, the posterior genu and the descending mastoid segment all avidly enhancing. That's a good appearance for a herpetic or a Bell's palsy. We want to think about the fact that we shouldn't normally image a herpetic or a Bell's palsy. The only problem here is that a Bell's palsy is not really a Bell's palsy until it goes away. Until it goes away, we want to think about other things like perineural tumor spread and look very closely at the parotid to be sure we don't have a mass at that level. Now, facial nerve schwannomas, when they happen to the facial nerve, are very interesting because depending on which segment that's involved, they may have a very different appearance. On CT, we like to see a tubular mass with scalloping of the bones, but on MR, we often see avid enhancement of small schwannomas. When they get large, we sometimes see intratumoral cysts. So if we have a facial nerve schwannoma that is isolated to the internal auditory canal, it's going to look a lot like a vestibular schwannoma. So it's important anytime we think we have a vestibular schwannoma laterally in the internal auditory canal to look very closely for the tail of enhancement that we might see along the labyrinthine segment of the facial nerve to differentiate a facial nerve schwannoma from a labyrinthine schwannoma. So anytime we have an enhancing lesion in the IC, look very closely at that labyrinthine segment to be sure it's not actually a facial nerve schwannoma. Here's an axial CSF bright sequence, T2FSE, Fiesta, KISS, space image, but we see a filling defect within the cisternal segment and the IAC, and they cut this lesion out thinking it was vestibular schwannoma, and it turns out the patient's face was paralyzed postoperatively. What they didn't notice was that the labyrinthine segment was very thick, and we have avid enhancement all the way to the geniculate ganglion. And this is actually a facial nerve schwannoma at that level. So it's very important to look for this tail of either enlargement of the labyrinthine segment or this tail of enhancement to differentiate a facial nerve schwannoma from a vestibular schwannoma. Now, if the facial nerve schwannoma is centered at the labyrinthine segment, we have very dense bone here of the otocapsule, so we have the classic osseous appearance of benign scalloping of that bone with avid enhancement all the way along its course to the geniculate ganglion. At the geniculate ganglion, if we have a facial nerve schwannoma involving that area, here we see that benign scalloping on this axial bone CT, and the correlating T1 without contrast, we see a soft tissue mass that nicely correlates with that CT of this small facial nerve schwannoma. Now, if this were to enlarge, you would imagine that the path of least resistance might be the middle cranial fossa. So here's an axial T2 MR, and we see a lesion over here. Oh, sorry, here's some arrows to help you see it. Here's a lesion over here on this side, and it looks like we have a good CSF vascular cleft between the lesion and the brain itself, maybe a benign according of the brain. This was thought to be a meningioma, and similar to that first case, when they cut this out, the patient's facial nerve was not working. What they didn't notice was that this was actually arising from the geniculate ganglion at this level. So this is actually a facial nerve schwannoma. When schwannomas get big enough, we might see intertumoral cysts. The problem, just like that first case in the internal auditory canal, is that the facial nerve is relatively resistant to internal derangement. It turns out that some cranial nerves are more sensitive to external compression than others are to internal derangement. That's very bad in this case because a lot of facial nerve schwannomas of the IAC, about half of them may present with hearing loss because they may push the vestibular nerve up against the wall of the IAC. Now, the next segment of the facial nerve is a tympanic segment. We think about that being here under the lateral semicircular canal. So on this coronal CT, we're at the level of the duck head. The head of the duck is a vestibule, beak is a lateral semicircular canal, neck is going down to the basal turn of the cochlea. The facial nerve should be right here under the lateral semicircular canal or beak of the duck. In this case, we've lost the osseous bar and we have a large pedunculating lesion that's filling the oval window niche and extending down from the tympanic segment of the facial nerve. We can see here that it's pushing the ossicles out laterally. So here's an axial CT. We see the ice cream cone, and we have a soft tissue mass medial to it. So when we think about this, we're thinking about a cholesteatoma. So we want to try to figure out, is there any osseous destruction here that may convince us that this is actually a cholesteatoma? A cholesteatoma will start destroying the ossicles, but a facial nerve schwannoma will push the ossicles out laterally. So a cholesteatoma will destroy the ossicles, like this case here. This doesn't quite make sense. It's eating the ice cream cone before the ice cream scoop, but we don't judge. We see a soft tissue mass with some osseous destruction. So cholesteatomas, like ice cream, facial nerve schwannomas, not so much. We're just displacing it laterally. Here's an axial bone algorithm CT and the correlating MR after contrast. We see avid enhancement of this facial nerve schwannoma that was arising from the descending mastoid segment. We see how it extends out into those surrounding mastoid air cells. It may start to extend to the external auditory canal. Here's another similar case. This was a soft tissue mass found in the EAC. It was actually arising from that descending mastoid segment with avid enhancement consistent with the facial nerve schwannoma. Here's the coronal CT and the correlating post-contrast, that again showing a pedunculated lesion consistent with the facial nerve schwannoma at that level. Now, we do want to differentiate that from a venous vascular malformation, what used to be called a hemangioma, but they actually have osteoblastic activity on past specimen. So here we have chronic progressive facial nerve paralysis. On CT, we see avid enhancement with a spiculated bone, and it can look very invasive on imaging. So here in this graphic, we see a very vascular mass at that anterior genu of the facial nerve itself. And here's a correlating case, nicely the graphic, the axial CT on top and the post-contrasted MR on bottom of this facial nerve venous vascular malformation, avid enhancement, and unusual enlargement and spiculated bone that's being laid down. We also want to differentiate that from perineural tumor spread, especially if we have a minor salivary gland tumor in the parotid gland itself. And again, we look for that fat density there. So here in this graphic, we have a tumor within the parotid that's crawling up that descending mastoid segment. And here on the axial post-contrasted MR and here on the oblique sagittal, we want to differentiate a herpetic or a facial nerve palsy from perineural tumor spread. Here we have a tuft of enhancement in the lateral IC, so that's good for a herpetic or a Bell's palsy. But if we have a tumor in the parotid, like we see in this case, on the coronal T1 before and after contrast with avid enhancement, that's consistent with perineural tumor spread. So anytime we think we may have a herpetic or Bell's palsy, we want to look closely at the parotid to be sure we don't have a tumor at that location. We can also have metastatic disease to the CP angle and IAC. We can have peel mets, we can have dural mets, we can have flocculus, tuft of wool mets, or mets to the choroid. Specifically for the facial nerve, we can have dural metastatic disease like we see in this case along the IAC, or we may have peel metastatic disease with enlargement of the nerve with avid enhancement. Another thing we want to differentiate that from is a herpes zoster oticus or Ramsay Hunt. Here we have avid enhancement along the facial nerve, a little bit more linear enhancement in the IAC, a little bit different than the herpetic or Bell's palsy, but clinically they have a vesicular rash on the pin of the ear to help us make that diagnosis of a herpes zoster oticus. So that's a grand tour of the anatomy and pathology of the facial nerve with some of the more common pathologies that we see. So you can see from this imaging spectrum that we can sometimes differentiate between these pathologies. That's very important for us. So I thank you very much for your attention and hope you now have a better understanding of the anatomy and the pathology of the facial nerve. Thank you very much.
Thanks, Rick and Christine. Those are amazing talks, very educational. So let me share my screen here. We had a few questions on the chat box. The first one was for Dr. Glastonburry. A lot of questions about the trigeminal neuralgia protocol.
Absolutely, yeah, and that's really important. So, here's in a nutshell. It's pretty straightforward. Every sequence is an 18 centimeter field of view, 3 skip 0. Whether you're on a 1.5T or a 3T, I don't care. You can do it either way. Everybody gets an axial and a coronal T1, T2 fat set, and post-contrast fat set, okay? I always do a diffusion because I love diffusion. I do that on everybody. And then everybody is going to get an axial sub-millimeter high-resolution T2. So that's either, it's called CIS or Fiesta, whatever it's called, T2 space in your shop. It's that sub-millimeter, and that is really important. But in anybody who has a history that is trigeminal neuralgia, we always add on to that a 3D time of flight MRA. Because I think when you're looking at the CP angle on the Fiesta and CIS, you really need to also have up next to that the time of flight so you can be exactly accurate about which vessel it is and what's going on and is it a vein or an artery. So I always want to put that next to the Fiesta or CIS when I'm looking at the vessels for neurovascular compression. So yes, so 3 skip 0, 3 millimeter axial and coronal T1, T2 fat set, and post-contrast fat set, plus axial Fiesta on everybody. And then we add into that the MRA as well for if the history is trigeminal neuralgia.
Thanks.
Does that cover everything?
That's great. Rick, do you have any comments?
Oh, yeah. For us at my shop, the vascular loop syndrome seems to be the biggest thing. If they really have trigeminal neuralgia, if it's really coming from somebody that you believe. So for me, the space is the biggest, most important sequence. So I try to get that first. Do very thin CSF bright sequence. So whether you're doing a KISS, a space, Fiesta, T2 FSC, whatever kind of scanner you have, try to get that CSF bright sequence first. Then as much thin sections as you can through that anatomy. And as Dr. Glastonburry mentioned, anytime you have an isolated cranial nerve deficit, we really have to think about imaging from the origin nucleus all the way out through the end organ. So for most of those, if you start behind the pontomedullary junction and go out through the face, you cover the area of interest. So when we can think about those main central cranial nuclei 5 through 8 being in the pons, 1 through 4 being above in the midbrain or mesencephalon, and 9 through 12 being below in the medulla. And then we can, go look up the anatomy later if you want to. But if you just get thin sections from behind the pontomedullary junction through the face, you've usually covered the area of interest.
How often are you adding a vascular study with the conventional MRI? So like a MRA associated with the MRI?
Every time it says trigeminal neuralgia, even if it's going to turn out when you later look at the medical record, it's not neuralgia, every time I do the MRA, the time of flight, I now have like absolute confirmation. I think on the T2, the space, Fiesta, CIS, whichever you call it, I think sometimes it's really hard to be sure what vessel you're looking at. And I find it just makes it so much easier. And then I can do pretty 3D images. It looks nice. But I like to be really confident it's this vessel and it's doing this here. So.
Do you fuse the images with the MRA with the MRI?
No, I don't. I just put them next to each other. And it's the source images that is really critical when you put them next to each other and you're scrolling through. Yeah.
Very good.
I'm dying to see the answers to your cases, Bruno.
Yeah, I have that saved up. So Rick, there was Paul had a question about finding the nerve.
Yeah, I can ask that, and there's another question here in the chat related to the facial nerve, maybe that we could post to Dr. Wiggins as well. But I really like the suggestion of looking laterally at the geniculate ganglion, something that Dr. Curtin would always do in the reading room, and that I'm in the habit of doing now, and trying to get my trainees in the habit of doing, is looking at the KISS or Fiesta along the medial aspect of the mass. to try to determine the relationship of the facial nerve there. Because of the anatomy, if it's a vestibular schwannoma, you would expect the facial nerve to be going anteriorly and superiorly rather than right into the mass. So is that something you typically do or would advise our audience members to do, or is looking laterally generally sufficient?
For any lesion in the IAC, you could try to guess. If it's way lateral, sometimes you can see that horizontal crest in the vertical bar or crista falciformis and Bell's bar to separate them. But you always try to mention how much CSF you see lateral to the lesion within the IAC. That may make a big difference if you're at a shop where you have neuro-ontologists who are thinking about a translabyrinthine approach versus a neurosurgeons who are going to do a posterior fossa approach or a middle cranial fossa. It may change the approach for the surgery. But yeah, anytime there's a filling defect in the IC, we try to guess, is this a little more anterior than posterior or superior to inferior? And we can sometimes guess what the nerve is. Where the nerve comes out and goes through the face with the pes anserinus, we can find that big vein behind the mandible, the retromandibular vein. And we think about the facial nerve going just lateral to the retromandibular vein. The parotid gland itself, embryologically, does not really have a superficial and a deep lobe. But on cross-sectional imaging, we think about the facial nerve as dividing it. If you look at very thin axial T1 sections, you can often see the nerve. If you can't, though, if you find the retromandibular vein, it's going to go from the stylomastoid frame and just lateral to that retromandibular vein. So that helps you find that anatomy.
Thanks, Rick. I think that answered one of the questions that was in the question answer box. The other question they had about the facial nerve is, how do you go about considering what is abnormal enhancement from normal asymmetric enhancement?
It turns out we are very judgy. We're constantly looking at images all day long and deciding whether or not they're normal.
No, you're judgy.
For the facial nerve, that is abnormal. So about 2/3 of the patients will have asymmetric enhancement of the facial nerve, and about 2/3 will just have some enhancement at all. So we see it most commonly at the geniculate ganglion, then the tympanic segment, then the labyrinth, then the mastoid. But we shouldn't see any enhancement on the cisternal segments. But this is something that is evolving. I can tell you that 25 years ago, we thought that you shouldn't see any enhancement of the intertemporal portions of the temporal bone. And as Dr. Glastonburry mentioned, this is an important thing, it turns out, with perineural tumor spread. We can think about an arterial neuroplexus that's around all the nerves. Sometimes patients who have perineural tumor spread, we see enhancement, then there's not enhancement, then there's more. But when they do surgery, it's tumor, tumor, tumor. So there are radiologic skip lesions with perineural tumor spread. So again, you need to think about imaging from the origin nucleus all the way out through the end organ anytime there's an isolated cranial nerve deficit. And just because it stops enhancing, don't stop looking. Think about where it goes and try to follow along its course. Because that perineural tumor spread, if it's going back all the way and is touching the pons, he's probably not a very good surgical candidate anymore. You're not going to change that patient's long-term M&M by doing a maxillectomy or something on the face. And so that's our job to try to find that. And perineural tumor spread is not easy. It's probably standard of care for academic neuroradiologists to miss perineural tumor spread. If you don't look for it, you're not going to find it.
It's great. That's a great leading comment for when I show my case. So there was a question about why using T2 fat set. And I'm assuming that's a question for Rick.
Yeah. Answer that one.
Well, whatever type of scanner you're using. At my shop, we used to do T2 FSE with fat set. Then we moved on to, I think we played with Fiesta for a while. It depends on your vendor. We were using KISS for a long time, but I didn't like the KISS because it made these banding artifacts in the vestibule and in the semicircular canals, and the flow voids would often be bright and would mix in with the CSF. But with the space, they're very dark. So we get great dark flow voids with the space, and you see it with the bright CSF around it much better. So on my scanners, and it depends on you and your vendor and everything else, but on my scanners, I feel like the space show me these cranial nerves very nicely. And I can get great pictures where I see the optic nerves and 3 coming out in the front, 4 coming in the back, the big fibers of 5, 6, 7, and 8 coming out, and then 9, 10. I can see all those cranial nerves very nicely. So I prefer the space on my scanner, but depending on your vendor and the coils and your technique, that may be different for you.
Yeah, we use the space as well. We like the space very much.
Like there was one other protocol related question asking about MR neurography specifically related to peripheral branches of V3 and oral surgery and maybe a neuroma after operation. Dr. Glastonburry, is that something you're doing? Any words of advice?
So there's a really beautiful paper on this, and it's killing me because I cannot think of the name of the authors who did this. There is a really pretty paper, and they look pretty. We just did another one like 2 weeks ago, and of course the patient was moving all over the place, but I think she has a neuroma. It's really what you're trying to do is get those very long T2 sequences. You want really good anatomy, really good, very, very long T2 weighted sequences. And I mean, it's like doing neurography anywhere else. You've got, even more so than any other time, you've got to know where the nerve branches go. So it's just basically a high resolution way of looking at nerves. People are trying DTI too. I'm not doing that at the moment. There's only so many things one can master and keep doing every day. But we're not doing DTI routinely, but yeah, we do some occasional.
I am aware of a radiographics paper, I think from Dr. Chabra's group at UT Southwestern. Is that the paper you have in mind? Or?
That's the one I'm thinking of, yeah.
Yeah, and also Ari Blitz has written a ton about it.
Yeah, Ari Blitz has some very nice protocol imaging, especially along the cavernous sinus using post-contrast, heavy T2 weighted image showing that nice enhancement along the cavernous sinus, where you can actually see the nerves as they go through the cavernous sinus.
Absolutely. He is just some of the most gorgeous imaging. Yeah, really beautiful.
So, Paul, I think I'm going to go ahead and show the first case. So that was my first warm up on Twitter last week. So this was let me see if I can make this move here. Okay. So this was a 70-year-old that presented with this female, presented with right facial paralysis and got an MRI. And so here I'm showing you at the top the T1 pre-contrast without fat set. At the bottom is the T1 post-contrast with fat set. So as I heard many times as I attend the annual head and neck meeting, as a head and neck radiologist, one of your favorite sequence is the T1 pre-contrast without fat set, right? Because we like that fat. We like to see the evil gray replacing the fat. So looking at the right side here, you see right posterior to the mandible, there is this lesion you compare to the contralateral side. So you see this lesion here just wrapping around the mandible on the right side, and as you scroll up, you can see the masticator space. And I don't think I show you this image. There is some replacement of that fat. Compare that to the contralateral fat. So there's something going on in the masticator space. So how we put together these two talks? So we have symptoms of a fifth nerve. We have now, symptoms of the seventh nerve, and now we're seeing something going into the masticator space along the fifth nerve. So here is the coronal MRI post-contrast, and you can see the enhancement here along the trigeminal nerve, so the third segment of the trigeminal nerve. You can see the foramen ovale here where there is abnormal enhancement. I usually tell my residents, if you can't find the foramen ovale, you find the pituitary gland, and right at the level of the pituitary gland, you're at the level of foramen ovale. So we were asked to biopsy this lesion. We did a CT guided biopsy because this couldn't be really seen on the ultrasound. And this turned out to be adenoid cystic carcinoma. And so what we're seeing here is adenoid cystic carcinoma in the parotid with perineural tumor spread along the auriculotemporal nerve. So here's just to show you the different example here of a large mass in the masticator space going up along foramen ovale. So I like to call when there's a fire going on in the masticator space, the smoke is going to go through foramen ovale. So it's like the chimney of your masticator space. So this is a nice article from Dr. Shamusu that talk about the auriculotemporal nerve and shows that connection between the trigeminal segment, the third, the mandibular nerve with the facial nerve. So when you look at the lesion in the parotid, you have to look for that perineural tumor spread. So that was my first case. I don't know if any of you want to make any comments about this case or anything regarding this perineural tumor spread. As was pointed out by Dr. Wiggins, as a head and neck radiologist, perineural tumor spread is one of the big challenges, and see where that tumor is going, because this really matters for radiation therapy. They want to know where all this tumor is going so they can plan the radiation field.
And also, that's a perfect example. It's easier to see on the T1 before contrast. It's actually harder to see on the post-contrasted if you're comparing right to left. We in neuro love symmetry. Some of us are more symmetric than others, but things that are midline and things that are symmetric are hard to see sometimes. So this is a great example of my point, that it's often easier to see. If you pay attention to where there's air and where there's fat, the pre-contrasted T1 is sometimes more important than the post, especially if you're doing CT a lot. It's much harder to see perineural tumor spread on CT, but you have to start off with a window, something like 440, so air is different than fat.
Especially, I think, with auriculotemporal and facial in the parotid, I think if you're just looking at post-contrast, I find the auriculotemporal super hard just at post-contrast. The pre-contrast to me is everything for anything in the parotid.
Absolutely. If you look at this image here, once you know that it's there, you can see the asymmetric enhancement, but very, very difficult to see at first hand. On the T1 pre-contrast, without that fat set, you can clearly see that gray area behind the mandible. Those are great comments. So I'm going to go to the second case that I posted last night as we were warming up for this amazing talk, these two amazing talks. And so this was a case, patient that had atrophy along the right side of the face. And you can see here, we see there's denervation atrophy of the muscles of masticator. So you see in the masticator space, there is atrophy of the pterygoid musculature. You can see there is also atrophy of the mylohyoid and the anterior belly of the digastric, which are two of these nerves at the floor of the mouth. They're going to be innervated by V3. And on the axial, you can see the atrophy in the masticator space along the muscle of the mastication. And then this was a meningioma right next to the cavernous sinus, going into the cistern, compressing the nerve and causing this chronic denervation atrophy along V3. Well, that was my second case. Any comments? I'm going to go to the QA. I'm using one monitor here, so it may show.
I've answered a few questions in the Q&A, but I also put in there the reference, and I also put it on the chat function as well as on the Q&A, the reference of the article I was thinking of, which is an AJNR article about MR neurography for that very specific thing someone was asking about, which is the post dental work, and they're looking for a schwannoma.
Yeah.
Yeah.
The other question that's worth answering live, if you guys wouldn't mind, is regarding neurovascular compression. And how do you distinguish abutment from true compression? Somebody asked.
Well, so there's two things. When people talk about NVC, it's supposed to be neurovascular compression, but neurovascular contact is the other. And neurovascular contact is incredibly common. And the distinction is not, is there a vessel near there, but is there change in caliber of the trigeminal nerve, which is neurovascular compression. So it both comes out as NVC, but you're supposed to be looking for compression, not contact. So that means you got to have really nice coronal images. And the axial fiestas I reformat like upside down, inside out, left, right, coronal, everything. But I really like the coronal T2 to have that as a baseline to take a look, is there any asymmetry? But the fiesta, cis, T2 space, whatever you use is your sub-millimeter, heavily T2 weighted imaging. You're looking for a difference in caliber of that cisternal nerve.
That's very helpful. And recently, there have been reports of neurovascular compression affecting the trochlear nerves, which I think is an even more difficult call because there is vascular proximity and the nerve is so small that you're lucky if you can even see it, let alone determine if it's truly compressed.
Right. They present with a myokymia.
Book with 12 chapters. Each chapter was a cranial nerve that he swears up and down was a vascular compression out that he cured with decompression and Teflon pledgets.
Yeah. So I've seen that's trichlea, the myokymia. I've seen cases as a here's a case sort of thing, but I've never seen one myself. I cannot claim to. I can't even see the nerve most of the time. So
great. Well, thank you all so much. That was a really terrific session. Thanks, Christine and Rick, for wonderful talks. Thanks, Bruno and Paul, for your excellent job of moderating. And thanks so much to our global participants for joining us. And we hope you'll register for the ASHNR virtual meeting. There's very reduced registration, even more reduced for international registrants. And then those who do register will also be able to access recorded material after the actual meeting.
Thanks, Kelly. As I have here on this slide, the meeting will be September 9th to the 13th. Hope you all can join. If this is your first time join the ASHNR webinar, you can see the quality of lectures and the outstanding speakers that are going to be lining up for the meeting coming September. So looking forward to see all of you there.
thank you very much. Thank you for coming. Thank you, Bruno. Thank you, Paul.
Thank you.
Thanks, Bruno and Paul and Callie. Thank you, Dr. Glastonbury.